into it, I have about 8 minutes. I have a couple of videos to show, so hopefully I can, get those in on time. So this is basically diagnostic vitrectomy: when, why, and how. So the indications for vitrectomy in uveitis can be both diagnostic and therapeutic. I'm not going to touch on the therapeutic ones, although I've listed them there. But the diagnostic ones can be, typically you have as the name is suggestive, you have a dilemma, your query is not solved despite all your clinical exam, your radiological tests, and all of your imaging, or you just have a very high index of suspicion of either a malignancy, neoplastic etiology, or an infectious process that is rapidly evolving, and you're not able to come and make a very good diagnosis on clinical exam. Or it just has a lot of dense vitreous inflammation and precludes a pretty decent or even a semi-decent examination. And then you can also have certain atypical appearances where you might think that the diagnosis is A and you treat with B, but the response is not C, the response is D. So then you want to go back and recheck and reconsider, and then a biopsy might be indicated. So those are the diagnostic ones. I'll be touching on them. Yeah, so as far as the diagnostic vitrectomy outcomes are concerned, this is some data on what you should be realistic about when expecting when you take someone up for a diagnostic vitrectomy. So even with all of these tests done, about 44%, just below half the number you will end up making a diagnosis after a vitrectomy, and most of them would either be a lymphoma or have infection, and the infections would either be herpes or toxoplasma, and in our scenario maybe TB, but that's way down on the list. Diagnostic vitrectomy also can have therapeutic implications in which the visual acuity might also improve, so that's an added benefit. However, the complications must be known. The regular complications of vitrectomy, of course, with the inflamed eye, you have a higher incidence of retinal breaks, detachment, elevated IOP, and also low pressures. And I think something which also must be discussed with the patient is that 50% chances you might not reach a result, and you might need more invasive procedures also in 10 to 15. So I think those things should be known. These are just a couple of papers, our work, which we have done on this. I'm not going to dwell too much on that and get into two of my cases. And then the how part of it, I think, will be discussed in this. So this is one of the patients, a 62-year-old male. He had diminution of vision in the right eye for 3 months, left for a month and a half. It was insidious and in onset and also increasing. He was diagnosed as a right eye choroiditis elsewhere and was treated with tapering doses of oral steroids for 1 month with no improvement. That's the photo montage of when he came to us. And you can see it might be whatever, but it's not choroiditis for sure. That's the blown up right eye image, and you can see the grossly disorganized OCT with huge RPE bumps in the right eye. You can also see that although the acuity is fairly normal in the left, but just temporal to the fovea, you have that yellow subretinal kind of deposit, and you also have that subtle kind of sub-RPE deposit there. You have the leopard skin appearance. The clinical features are very, very suggestive of, given the age, the bilaterality, the presentation of a neoplastic process, a vitreoretinal lymphoma, but you want to look at extraocular things, you get your MRI done, the neurology consult, all of which were not helping, along with the CSF tap. So this patient had to be taken up for a diagnostic vitrectomy to prove the diagnosis and aid in management. So that's what we did. This is standard 25 gauge 3-port setup. The surgery was delayed 15 days because the patient was on oral steroids, so it's important to discontinue oral steroids. Because they have a lytic effect on lymphoma cells, and you don't want a false negative report in your cytology. The vitrectomy is begun under air, not typically as you would do in most of your vitreous surgery cases under fluid. The air ensures that the sample that you're aspirating, getting out of your cutter, is not diluted, so you can get an undiluted sample. It's a lot easier in pseudo-phakic eyes. It's also possible in phakic eyes, and you can get about 1 to 1.5 ml of a good undiluted sample under air. Of course, with the rider being that the cut rate has to be low. The cut rate has to be as low as about 800 to 1000, as much, as comfortable as you are without causing too much traction with your assistant or your scrub nurse actually aspirating passively. And after you've had a pretty decent undiluted sample, you switch back to BSS. And in phakic eye, you will have this problem of fish eggs happening because you'll not be able to clean up the whole of the vitreous cavity right behind the lens, but you'll have to work through that. And then you can actually have a pretty good diluted sample as well. to run a battery of tests. In this patient, I actually went a step forward. You can see that's the blown up image of the macula. You can see those, yellow subretinal deposits. There's some hemorrhage, and that blown up image actually there shows you, it's not it's visible there. The leopard skin appearance on top. I actually went ahead with a subretinal biopsy in this also, made a retinotomy with at the edge of what seemed like healthy and that non-healthy retina with a endodiathermy and with a passive 25 gauge flute attached to a 2 cc syringe left open to the environment. I actually went ahead and aspirated some of those cells, and these cells, because they're neoplastic, they tend to be non-adherent, and they will move up into the flute needle by capillary action. And the idea here is not to get all of these cells out. The idea is to get a good enough sample for you and your cytopathologist to be able to make a confident, good diagnosis to help the patient make a diagnosis and institute therapy. So after that was done, I'm just going to get that. After that was done, I went ahead with lasering that area, and this patient was actually left with 20% SF6 and given prone positioning. And because I was fairly sure of my diagnosis, I had also injected methotrexate at the end. So this patient, this kind of video showed most of the salient points of how a diagnostic vitrectomy goes, and why a subretinal biopsy may be required, and the advantage it offers over just a vitreous biopsy. Because in this patient, the vitreous yield was very low, despite a lot of inflammation happening, and the cytologist would not have been able to make a diagnosis just based on the vitreous. Diluted and non-diluted. However, the subretinal aspirate had very big cells, and I remember the cytologist actually calling me back and saying that these are the kind of cells they actually tend to look at, the lymphoma cells. I mean, in blood in patients who actually have leukemia lymphomas. Because there was no cutting involved in getting the cells out of the subretinal space, so the morphology of the cells was maintained. Hence, they could be identified very well. A positive diagnosis could be made, and then of course immunohistochemistry and all helped. So that is that. I'm just going to have one more case, and this is also something similar. A 56-year-old lady. She had diminution of vision in both eyes. Right for 8 months, left for 4 months. Was had hypertension, had a history of stroke 6 months back, had left hemiparesis. The MRI of the brain just showed what the neurologist at that point in time felt was sequelae of that infarct. And when she came to us, she had that picture. She had cells. The left eye showed the typical leopard skin appearance. The right eye had CME, and the traditional teaching is that if you have lymphoma, CME is not seen. That's untrue. But you also had these sub-RP deposits. So we went ahead and just going to finish with this. Went ahead with a similar kind of setup. This was like a hybrid vitrectomy. The 27 gauge cutter wasn't working that day, so I had to convert to a 27-25 mixed. But the idea was that, again, undiluted vitrectomy, began under air, got an undiluted sample. And after that, switched to BSS, was able to get a larger diluted vitreous sample so that, all the tests could be run, not just cytology, but immunohistochemistry and flow cytometry and your gene, the mid-88 gene rearrangements. And you could see that dull yellow temporal to foveal, kind of those deposits that will soon come into view. I'm just going to get that there, yeah. So after the vitreous was cleared, and again, I went ahead, because it was an easily accessible area. Just used the endodiathermy over it. Again, with the passive soft tip, 25 gauge, went into the subretinal space. These areas tend to be ischemic. Areas of chances of bleeding here are very, very minimal. In fact, some people, propose not lasering them, at all after a biopsy, which is something, quite frankly, my heart doesn't allow. But, with that, I was actually able to get some lymphoma cells into that. I could see that, although this was a very flat, thin lesion, and at the end of it, did some, the fluid exchange laser. And again, this patient ended up getting SF6. The vitreous, again, the point I want to show, vitreous, the yield was hypocellular. You had very few cells, and all those cells were labeled as degenerative and not neoplastic because the yield was low, and B, there were lots of smudge cells. However, the subretinal aspirate, which was passively taken out, had a lot of cells. So not only was the yield better, but the morphology was maintained, and they were easily able to make out that these are atypical cells, high nucleus-cytoplasmic ratio, more nucleoli, and hence a diagnosis was made, which was again confirmed with immunohistochemistry. So these are just two cases that I wanted to show and discuss regarding the technique of doing a diagnostic biopsy and adding a subretinal biopsy if a neoplastic process is suspected and it's a fairly accessible lesion. Thank you.
Thank you, Dr. Mohit, for such a nice presentation. So we'll take a couple of questions before we move on to the next talk. Anybody has, yeah. Yes.
Yeah. Thank you.
Yeah.
20.
Yeah, it doesn't matter, we can hear.
Okay. I'm fine.
You mentioned 25 and 27 gauge. Usually when we want to take a vitreous biopsy, because we want the cells to be there, we tend to use 23, sometimes even 20 gauge cutters because we don't want cytology to be disturbed. But you mentioned 25 and 27, that's why I asked.
That's fine.
And also the soft tip cannula versus an open cannula which you can suck. Why do you use a soft tip?
So I use a soft tip, ma'am, because, so again, so the first question first. So actually when getting the cut rate down all the way down to 600, 800, no matter what the gauge is, I don't think should matter as far as, getting a good morphology of those cells is concerned. The idea is not to have the cutter going like that because that's going to break up the cells, get a lot of smudge cells and, give you lots of artifacts. So getting it down, the cut rate down, irrespective of the gauge, I think is the way to. I don't think the gauge matters, and also I think in general, because these patients tend to have a higher incidence than regular non-inflamed eyes of retinal breaks, maybe not retinal detachment. I think a smaller gauge cutter as compared to a 20 gauge would also help in that regard. So I don't think that would matter, ma'am. And as far as the choice of using the 25 gauge soft tip is that because the soft tip is longer. So if it's like in the second case, if there is not like if the lymphoma cells aren't too high, if it's like a flat thin sheet, I think it's easier to get in akin to a snake burrowing into its getting into its burrow. The actually soft tip can go in. And I actually had another video in which I've done MIOCT also, in which you can actually see those lymphoma cells march up into, passively through capillary action, march up into that. And the liquid and those cells will just collect in that hub of that 2 cc syringe passively. And then it's easy to just, withdraw it, get the plunger back in and send the whole syringe. And that's, I think for me, I've had 8 patients. And in fact, there's a series I'm also presenting here, one of the free papers in which I did both a vitrectomy as the first procedure and a subretinal biopsy at the same count, and out of those 8, 3 had positive both vitreous biopsy and subretinal aspirate. However, all 8 had subretinal biopsy positive. In 5 of them, the vitreous they weren't able to get on cytology only because they had artifacts, the yield was low and the smudge cells were. So I think the soft tip helps in that regard because it just passively sucks those cells. Whereas the cutter, even if the cut rate is down to 600, there will be some amount of cells which will be chopped up, and hence I think the loss in morphology and the lack of positivity there. Yes.
Yeah.
Absolutely.
Dr. Manisha? Yes.
So Mohit, very nice cases that you showed.
Thank you.
I just had one comment for the first case because the hemorrhages over the lesion were very misleading. So the first thing which comes to your mind is some infective pathology. So how often have you seen lymphomas with these associated hemorrhages?
So again, ma'am, so in that patient, I think both the eyes told, a pretty telling tale. I had good imaging of that patient, but had I put in lots of imaging, I would have overshot time even more than I did. But I had OCT through those lesions. The left eye had those typical yellow deposits with those brownish kind of, it was a clinically visible leopard skin appearance there. The right eye, absolutely, ma'am. But the fact that the patient had bilaterality, the age, the disc edema, and also just temporal to those hemorrhages, the area in, during surgery from where I actually took those cells, you could see a similar pattern as was seen in the other eye. So a cursory examination, yes, did, confuse us a bit, especially the patient had been exposed to steroids. So it didn't, the right eye didn't initially didn't scream lymphoma, the left eye did. And also I think during vitrectomy, once you can get the vitreous out completely, sometimes those subtle lesions are visible a lot better after the vitreous is out. I think that also helped.
And do you think that taking it with the soft tip, does it increase your positivity rate in cytology? Because
Absolutely.
in my hands, it's extremely poor.
From the subretinal space, yes, ma'am.
Okay.
From the, I've yet, of course, with the pre-test probability and a pre-test diagnosis of a clinical suspicion, very high suspicion of primary vitreoretinal lymphoma, patients in whom, and I've had 8 of these, in which I've had to do a subretinal aspiration through this, combined with the diagnostic. I have not had a false negative.
You do that in all cases?
In which it's accessible. So if it's at the fovea, if it's too small, if there are no lesions, I would not go into the subretinal space. But if it's, thick, if the visual, prognosis is poor, the whole macula is involved, or if it's very superior. Again, had a patient just had a superior above the arcade, 2-disc diameter yellow deposit. So that's very accessible. But I won't go into the fovea or even in the macula just to get that sample if it's not accessible, man.